Thanks so much. Thanks to SAGES and the session coordinators for the invitation. There you go. So liver mets, as Thor has just showed you, occur in the majority of patients who have GI primary neuroendocrine tumors. I'm saying 9 out of 10 because if you keep them around long enough, they'll almost always get liver mets. It's the most common and often only site of disease progression, even if there's disease outside the liver, and if not controlled, is a prominent cause of death in this patient population. So if we look at the NCCN guidelines for liver-directed therapy, and these from 2017, but it hasn't really changed very much, basically we look at patients who are either progressive or symptomatic on an SSA, and have liver-dominant disease pattern. For people who have hyperserotonin syndromes, you can try adding talotrestat for symptom control, but basically, once you've failed first-line medical therapy, then you need to consider some sort of debulking therapy, and of course that could be surgery, that could be ablation, or that could be embolization. So if you're going to go the embolotherapy route, we have several questions to ask. How good is it at symptom control? How good is it as a debulking strategy? How durable is the benefit? How beneficial is it in patients who have disease outside the liver? And of course, what's the price that you pay? So there's decades of retrospective data and very little prospective data, so I'm just going to put together a summary. A lot of this is taken from some very large systematic analyses. This came out of surgical oncology quite a while ago, but I think the numbers haven't changed very much. If you look at clinical response rate, meaning improvement in symptom control, it's excellent, probably around 85%. So certainly, it's probably the best thing about doing liver-directed therapy is managing patients who are symptomatic in the setting of an SSA, because even if you don't have to achieve an objective response to greatly decrease their hormone secretion rate and make them feel better. As a debulking strategy, if you look at objective response rates, again, they're all over the place, but they tend to run around 65, 55%, depending upon whether you're looking at bland embolization, chemoembolization, or series that use radioembolization. So overall, what I tell patients is 55, 60% objective response rate, meaning a RECIST response or better. More importantly, how long does that last? And again, there's data all over the place. So this is just a graphical representation. So the dark blue column is bland, the tan column is TACE, the light blue column is yttrium, and then the red column is drug-eluting beads, for which there's very little data. And you can see incredible ranges of PSF that have been reported across all of these. But if you kind of look at the middle, where they kind of average out, it's somewhere around 18 to 20 months after your first cycle of embolotherapy. One thing that's important to remember is that embolotherapy is not a one-shot procedure. It's you do a cycle of embolization, treat all the tumor burden, and then if it works and it's durable and the patient relapses in the liver, as they usually do, you can do it again. So it's not like you are moving on to the next line of therapy, and in fact, you may embolize people with repeated cycles over time until you either can't embolize them anymore or they develop enough extrahepatic progression. So this is the cloudy term of TTUP, or time to untreatable progression, which many people have tried to define in clinical trials, and I can tell you is extremely difficult to define and codify in a uniform way that is used evenly across all institutions, but it has been done. And there's a paper that actually just came out from Gustave Roussy in Paris, where they looked at their long-term outcomes, and their TTUP with up to 4 cycles of embolotherapy was 26 months. So that gives you a sense of the durability. How about patients who have extrahepatic disease? So this is an article from Annals of Surgical Oncology with a compared cohort of patients who had extrahepatic disease versus a cohort that did not have extrahepatic disease. And you can see that 2-year progression was the same in both groups, 70%, almost all of whom had progressed in the liver, and 3/4 of whom had progressed in the liver only, despite having disease outside the liver. So the liver is the dominant source of tumor progression in these patients, even in the setting of extrahepatic disease, and so control of the liver is paramount, because what they'll die from is liver failure. And the majority of patients with extrahepatic disease will progress in the liver as their first site of progression. And then what's the price you pay for all this? Well, if you look at practice guidelines from the major societies, you expect a serious adverse event rate of somewhere in the 6 to 10% range after embolotherapy. Most of that's going to be a self-limited post-embolization syndrome, and mortality is quite low in the 0 to 2% range. So now the question is, how are you going to embolize them? So this is very interesting data from a practice survey. It's about 10 years old, but they surveyed over 260 interventional oncologists around the country and said, what technique of embolotherapy do you use for these different oncologic scenarios? And you can see for cholangio and colorectal cancers and various presentations of HCC, there are very strong biases in what technique they use. But for NETs, it's a wash. So roughly 25% of people do bland, conventional TACE, DEBS, and Y90, which means clearly we have no idea what technique works best, at least historically. So we did recently a multi-institutional survey where we pulled data from half a dozen or so major centers around the US and got data on 182 patients who were treated with each of these various modalities. We had to exclude some for incomplete data. So at the end of the day, we had about 150 odd patients who had either CTACE, re-embolization, or bland embolization. And what we found is the things that matter were not surprising. So tumor grade mattered. So there were statistically significant differences in both hepatic progression-free survival and overall survival, regardless of embolotherapy modality, between grade 1 and grade 2 and between grade 2 and grade 3. Not a surprise. Also, tumor burden mattered. This has been reported many times over the years. In most series, it's pretty consistent that patients with heavier tumor burdens don't do as well. So in this case, we just split it as greater than 50 or less than. We had gotten the data in quartiles and ended up lumping it into more or less than 50% liver involved by tumor. And again, you can see both progression-free survival and overall survival decline if you have more than half your liver occupied by tumor. Again, not surprising. What didn't matter was primary site. So unlike for some of the drug therapies where some things work better in PNETs versus lung versus small bowel, it doesn't really matter what the origin of the tumor is when you do liver-directed therapies. So both PFS and OS are the same whether it's a pancreas, a small bowel, or a lung primary. Other things that didn't matter, at least in this retrospective survey, was technique. So there were some trends within the population, but at the end of the day, there was no statistically significant difference in oncologic outcomes between any of the three techniques, both for OS and progression-free survival, and no significant difference in safety in terms of SAE rates. So we used some of this information to help us plan our prospective study, which is the RETNet trial, which is 15 centers all around the world, including San Rafael in Italy, but also Canada, South America, and the US. Subjects started out being randomized among bland embolization, conventional TACE, and DEB-TACE. There were some concerns about the DEB-TACE arm because of prior reports of safety issues, so there was pretty strict and early safety reviews. The overall hypothesis driving the study was a roughly twofold improvement in hepatic progression-free survival using a chemoembolization technique versus bland. The DEB arm actually closed at the very first safety review with twice the threshold level of serious adverse events that we even were allowed in the study. So this is actually the third prospective trial and the first randomized one showing that drug-eluting beads were unacceptably dangerous to be used in neuroendocrine tumors, and in fact, we've already changed the NCCN guidelines based on this. So now drug-eluting beads are prescribed in the NCCN guidelines for this. So we've carried on with the other two arms of bland versus CTACE. I'm happy to say that this month we should complete accrual. We only need 4 more patients. So I'm hoping by the end of March we'll have completed accrual, and then of course we'll have to wait another year or two for the readout in terms of the oncologic outcomes. We'll of course have the toxicity data, adverse events data, and we've also collected quality of life surveys longitudinally on all these patients. So we'll have patient-reported outcomes as well. So I hope to be able to come back in a couple years and tell you the answer. What's the role of Y90 now? So I can tell you that as of 2 years ago, in the NCCN guidelines, Y90 therapy was considered controversial and actually had only a 2B recommendation. Part of the problem is concerns about layering it with PRT, which are really unfounded. There's no data saying that there are problems with doing sequential re-embolization and PRT in either order as yet. However, there is concerning data that's come out of Oregon and Northwestern and Penn that in neuroendocrine patients, because they live such a long time, that after 2 years, a certain percentage of patients will develop end-stage liver disease from late radiation fibrosis. So they essentially will develop a cirrhotic pattern of disease in the absence of tumor progression or other hepatotoxic therapy, therapies that doesn't manifest itself until years after they got Y90. And Oregon reported this in 12% at 1 year. Northwestern found it in 40% of patients after 2 years that they had clinical hepatic decompensations. At Penn, we looked at 100 patients almost. 13% developed clinical hepatic decompensation as adjudicated independently by a hepatologist and a radiation oncologist, and 5 of them died from end-stage liver disease in the absence of tumor progression. So this has led to some rethinking of how Y90 should be used in NET patients. Probably the most important thing is you should not do whole liver therapy. That, just as the radiation oncologist would have told you for decades, you always spare 700 cc's of liver if you're using external beam radiation, we should do the same thing. You should spare 2 segments of the liver when you're doing Y90, and if you can't do that, you probably shouldn't be doing it at all. Also, dosimetry has gotten much better and much more advanced and complex than it used to be, so we're getting much better at targeting the tumors with appropriate therapy while sparing the normal parenchyma toxic levels. So the current NCCN guidelines elevated radioembolization up to a 2A, but very specific applications. Not whole liver. It is preferred in patients who have prior biliary intervention because of the high risk of abscess formation after TACE in patients who don't have a sphincter Ravati, which is greatly reduced if you do Y90. And of course, the other issue that comes into play is post-embolization syndrome. So if you have patients who are too frail to tolerate the post-embolization syndrome from TACE, then TARE is the kinder, gentler approach. Now, one interesting thing we've been looking at recently at our institution is actually using Y90 in combination with CAP-TEM therapy for patients with more aggressive presentations. So patients who have G2 tumors and extrahepatic disease but are still liver dominant, both capecitabine and temozolomide are classic radiosensitizers used for lots of GI cancers and brain cancer in combination with radiation therapy. So we developed a regimen where we start the patients on CAP-TEM. We make sure they go through 1 cycle that they can tolerate the CAP-TEM. During that first month cycle, they get their mapping angiogram for the radioembolization simulation. And then, assuming they pass both of those, then they go on their second cycle of CAP-TEM and they get their first radioembolization on day 7, and then they get their second one on day 7 of the next cycle, and then they stay on CAP-TEM as long as it's working and the patient can tolerate it. So we published our feasibility study back in 2018, which showed that this was a feasible and tolerable regimen. The objective response rate was 62%, including 4 complete responses, and the PFS was an astonishing 31 months, which even I don't believe. So we've now been able to use this data to power a phase 2 trial. So now we have a multi-center phase 2 trial open to do about another 50 patients. I can tell you that in the years it took to get the phase 2 trial designed and funded, we've continued to use this particular regimen in this specific group of patients. We've now treated about 40 patients, and surprisingly, the PFS is holding up at about 31 months. So this is an interesting aspect of using Y90 therapy that needs to be further developed. Of course, PRT is our recent competitor based on the NETTER-1 study, but there are a number of issues with PRT. So they did a post hoc analysis looking at tumor morphology and how it affected response to PRT, and one of the things they found was that tumor burden did not matter. So there was no difference in PFS if you had less than a quarter of your liver occupied by tumor or more than half, which no one would believe. And conversely, they found that if you had any lesion greater than 3 centimeters, then your progression-free survival dropped from 90% to 60% at 18 months. So you're telling me that having half your liver taken over by tumor doesn't matter, but a single 3-centimeter tumor does. So I don't think any of us really believe this is true, but it's really started, this is permeating the community and it's starting to affect trial designs. So for instance, there are now trial designs coming through NCTN where they're saying, okay, patients who have a heavier tumor burden should have surgery first or some other debulking therapy. You guys take out all the 3-centimeter lesions and then we'll do PRT for the rest. So this is influencing trial design in the modern era. The real question is, what do you do when? As Thor alluded to, everyone can get all these therapies in any order. How are you going to sequence them? How does embolotherapy or surgical debulking fit versus targeted therapies, CAP-TEM or PRT? Each have variable response rates and durations of response, but I think the bottom line is you can get these all in sequence, you'll end up with the best possible outcome. So in conclusion, embolotherapy does provide durable control of mets to the liver. There's no evidence to favor one technique yet, except that you should not use drug-eluting beads and be careful with how you use Y90. Sequencing with surgery and systemic therapies is obviously the key chore for our multidisciplinary teams. And then of course, synergies of combinations is the whole better than the sum of the parts remain to be explored. Thank you very much.